So my charge here today is to talk about surveillance of low-stage kidney tumors, and I use this word kidney tumors pointedly rather than renal cell carcinomas because the entry point for now most of kidney cancer diagnosis is a mass, and these are not all kidney cancers, which is an issue that we're going to come back to. And without going citing all the individual literature on this, just the issues of why is surveillance so topical, and there was a question here just now we touched on, and I didn't put the VHL experience of the 3 centimeter rule, and I'm unaware of anywhere in the world that a patient with VHL who's been diagnosed incidentally with an asymptomatic tumor and a kidney tumor and no pre-existing metastases has metastasized up to the 3 centimeters. So we are seeing a disease here of small renal mass, let's call it, and many of these people are older. We don't actually know what the average age of small renal mass at diagnosis is, but kidney cancer is in the early 60s, so we're supposing it's similar, and there is increasing comorbidity, and we'll come back to this in our talks later today. Interestingly, new renal cell carcinoma patients have, at least we believe, they have a higher incidence of CKD than the general population, which may in fact be a promoter, maybe even an initiator of renal cell carcinoma. And when we look at the long-term dialysis population, we see a much increased incidence of small renal masses, which speaks to that. Quite a few of these incidentally detected tumors are not renal cell carcinoma, which is an argument in favor of surveillance, and it's probably a quarter, sometimes even higher with smaller masses. When we do diagnose a renal cell carcinoma in these small renal masses, they're frequently low grade, and there's a disproportionate non-clear cell representation, which some of these other subtypes, as we may hear in the pathology talk coming up, have a different natural history. When we look at the number of treatments for kidney cancer, particularly in America, it's increasing dramatically, but there isn't a change in mortality rates, at least yet. And that raises the question of whether we need to treat all these patients. And when we do look at proven RCC treatment results, we all know in this room that virtually 100%, certainly well over 90% of these patients are cured. And whenever you have a high cure rate, it raises questions about the necessity of treating those patients. And lastly, virtually all the fatal renal cell carcinomas present in more advanced disease, either with metastases or locally advanced. So there are a number of reasons to think about or rethink our initial management of these patients. So we and others have coined this term that I think is a useful clinical term, small renal mass, rather than seeing an enhancing asymptomatic mass and saying this patient has an RCC. If we say this patient has a small renal mass, it may produce some caution about driving the treatment. And it's important that we use this only for asymptomatic patients with no metastatic disease, and we wrote a little commentary on this last year that was published in the New England Journal. So this isn't a new concept. If you go back to, well, if we look at a couple of autopsy reports, one from Scandinavia, one from Poland, that there is an incidence of RCC incidentally discovered at autopsy, which we see in prostate cancer, we don't see in bladder cancer. So it's a marker of indolence. And 60 years ago, this was recognized by Bell, and this concept of adenoma. This is his book from our library in Toronto, and probably you've never seen this table, but what he looked at was autopsies, and when 3 centimeter tumors were detected incidentally, 44 out of 45 had no metastatic disease, and that's where we got this concept of Bell's adenoma. Then in the 80s and 90s, Morton Bosniak, a imager as we'd call him now at NYU, looked at retrospectively images from patients coming to the hospital for nephrectomy and found old IVPs, or I guess that there weren't many ultrasounds in those days, but found that often these patients had had a mass they might have had some imaging for trauma or some other cause. And he actually calculated growth rates in these, using them retrospectively, and of course that supports the concept, the hypothesis. So this has led us to prospectively conduct a trial in Canada, which is why Tim asked me to present here, of active surveillance. And I know you in Britain have an interest in doing this and are doing it, and collaborating in Europe as well. And I thought it would be useful to share the results. So we're talking here about active surveillance, but an important part, as in prostate cancer, of active surveillance is you're delaying the treatment until there is a sign of progression or a need to treatment. So it's not just abandoning the patient, and you all know that, but not everybody knows that. And we have some special issues with kidney tumors and active surveillance. So how do we assess these patients? How do we actually do active surveillance? What are our outcomes? What are the risks of this? And lastly, and importantly, who should undergo in 2011 active surveillance? And I want to start with a discussion of needle biopsy, and many of you are quite familiar with this literature, but until recently, this was taboo. And one of the problems with the internet is nothing's ever erased from the internet. You just have to Google your pictures to see that. But when we look at kidney biopsies with tumors, we see many websites particularly caution our patients against having this because of implantation. And we've had quite a paradigm shift in the last years with the technique where we now can use sheathed needles, and we can really repeatedly biopsy a tumor with less complications. Implants we now know are rare. There hasn't been a report, although I heard today there might be one in Birmingham from Eamon. But for 15 years there hasn't been a report of implantation. We do these as outpatients, usually ultrasound, not always, guided, using a biopsy gun or some kind of automated needle. So we've published, as of others, about this, and this is a table of the cases that have had wound implantation. And you can see 4 of these were renal cell carcinomas. And as I say, there's been no recent report. So I say very confidently to our patients that you can have a biopsy, and your risk of having a complication, including implant, is low. And we've recently updated this experience, and in red are the sort of summary statements that when you do a needle biopsy, about 80% of those are going to be diagnostic, and this is usually due to a miss at the time, and often a junior house officer is given the task, and basically you have one chance, and it's like skewering a meatball in an oil bath. You don't get it on the first crack. You have a smudging, and then the second and third passes. For those of you who have done this yourself, you'll know that. If they are diagnostic, roughly 3/4 turn out to be renal cell carcinomas, hence that small renal mass concept. What we learned is that if you have a non-diagnostic biopsy and you repeat it, basically the same metrics apply. So 80% of them will be diagnostic. So you're at 80%, then you get another 80% of the 20%, so you're up over 95%. So we thought that a non-diagnostic biopsy was a surrogate for a benign situation. That's not the case. It just means you missed it, and that's a clear message. So when we look at the distribution, this is very similar to Eamon's slide, and really I give Marston Linehan the credit for publishing this, that in black is what we get from nephrectomies. So these numbers are surgical numbers. But when we look at biopsies, we see a few more chromophobes, a lot more papillary type 1s, and somewhat less clear cells, which perhaps explains some of the indolence of these small renal masses. And I don't think we're at a stage now where we can really say that if we get a biopsy that's type 1 papillary, that this means it's an indolent tumor and we can afford to watch it, although I must say that's our bias, as it is others. And I was interested in the 2 previous talks, and one of my questions related, can we actually get that kind of information, and can we serially biopsy these patients? And heterogeneity is obviously an issue. We know that in terms of grade, but is it also molecularly an issue? And these tumors are usually low grade. In fact, only 10%, I don't know if you can see the way this table seems to be in the way, but 10% of these needle biopsied clear cells are higher grade, meaning 3 or 4 out of 4 Furman grading. So most of them are low grade, and they are quite homogeneous across the tumor when they're removed. We rarely upgrade a tumor when we take out the lesion. So here are some cases to make this point about mass, as in many of you are clinicians, and it's wonderful to have pathologists in the room because pathology is so critical to this biopsy story. It's not a urologic story, it's a story of teams. The pathologist has got to be comfortable with the biopsy. The imager has to, in our situation anyway, the interventionalist has to get tissue for us. So there's a whole sensitization process. And we saw that in our Canadian trial, that we got much lower success rates in some centers that were less experienced on all fronts. So here's a 54-year-old woman who you can see a very central tumor that enhances on the axial and coronal images, and I suspect in Long Island this patient would go to the OR and have an expert laparoscopic or robotic partial nephrectomy. I don't know, what would you do, Lou, in Long Island? Professor Cavusi is one of the thought leaders in minimally invasive kidney surgery.
I think you're thinking correct.
Yeah, so I was hoping you'd say that, Lou. So we biopsied this thing, and it was an angiomyolipoma. So we can talk later about, does that really matter? But to me it matters, and we would tend not only to immediately operate on this patient, but would also moderate our follow-up program. So here's a 57-year-old man with a woman with bilateral masses, and that poses a problem. And as we now know, there's often discordance between the two tumors, and we biopsied the larger lesion, and it was a mixed clear cell and papillary. And what I didn't put up here is that the other side was an oncocytoma, or at least an oncocytic tumor. We rarely say the word oncocytoma. Here's a 64-year-old patient with bilateral tumors. You can't see so well on the left, but very nice exophytic lesion that's just waiting to be removed by the new minimally invasive surgeon on staff that's come back from a fellowship with Lou and is a robotic surgeon. It just couldn't be better. And we biopsied that, and it was oncocytic neoplasm. So those are some cases. Here's another one. This is a young man who moved from London to Toronto with his Canadian wife and had a baby 3 months before I saw him, and he turned up with this thing. And when we biopsied this, it came back as a translocation tumor, which obviously resulted in a surgical procedure right off, and uncertain what was going to happen there. So those are good examples to me of this. What used to be so simple, it was a binary thing. Saw the lesion on the imaging, took the patient to the OR for some sort of surgical procedure. It's a completely different ballgame. Eamon thinks it'll all be over in a year when we have genomic data. I'm not so confident about that, but at least we're moving forward in the front. So if we look at, we started a prospective trial in Canada about 7 years ago, and based on the hypothesis that I've already elaborated on, that most small renal masses are RCC, but the majority appear to grow slowly and rarely metastasize early, so that initial surveillance is a reasonable management option. So we gathered together, just got too many buttons here. We've just reported this this year in the European Journal of Urology. And what we did in this was and we really don't know better now, but what we did then is at 3, 6 months, and then 6 months thereafter, up to 3 years, we imaged these patients, and we initially started with CT scans. We now do sonograms if we can see the tumor, and if not, we'll try MRI depending on the age of the patient. We're pretty paranoid in Canada like you are, probably not as paranoid as you are about diagnostic imaging. And our endpoints were progression, which we defined this way. We used 4 centimeters as opposed to 3 to conform with the TNM, and also there's not a big break between 3 and 4 centimeter tumors in terms of metastatic rate and prognosis after surgery. We hypothesized that if they doubled in 12 months, that is volume, that was bad, and of course progression was clear if they metastasized. And we captured the treatment rate and what kind of treatments and outcomes, mortality, those that are off study, which turns out to be a big issue if any of you are planning to do such a study, because you're dealing with not only an anxious patient, and we met one on the street on Pall Mall this morning with Professor O'Brien, who is an anxious Londoner with a renal mass, I understood. But you also have anxious doctors, which is probably a bigger problem. We've learned that with prostate cancer for sure. And with this population of 204 tumors, we requested a biopsy. We weren't very aggressive about it initially. We were later in the study, and we got quite a few biopsies. So there were 178 patients. Our entry criteria were older and patients with either or infirmity, which we didn't define, and we still don't define elderly and infirm, but their mean age was 73, tumor size 2 centimeters roughly, and follow-up at the time of this report was 28 months. We're a bit stuck on this because we're having problems getting longer follow-up. The patients are dying, they're being lost to follow-up, so we're a little stuck at trying to get out. We have some much longer follow-up, but we don't have a mean follow-up that's going up as fast as we thought. I've talked about the progression. So there's 2 slides I want to show you from this study, and some of you have seen this already. This first one, to me, speaks to this biology and the genomics of kidney tumors. So the red bars here on this waterfall plot are renal cell carcinomas, and the height or the length, the negative value here reflects the change in the size of the tumor over the period that individual tumor was on trial. And what you can see here is about 40% or so of the tumors were staying the same or getting smaller, so a slight majority were growing, quite modestly in most cases, very few growing a lot. The one that was growing the most was actually a patient we didn't have a biopsy on, but you can see the red cancers are distributed fairly evenly across this waterfall plot. So just diagnosing renal cell carcinoma is not a marker initially in the short term for growth in these small renal masses. That's the first message. The second is that the growth rate on average was fairly modest, but it is not, average growth rate is probably not the important message here. It's the individual growth rates, and I've already told you that the growth rate wasn't associated with the histology. We had something in the order of 12%, it's really about 15% now, have progressed locally to meet our criteria, that is, and most importantly, we had 2 patients progress to metastatic disease. So 2 tumors out of 200 in 178 patients, so something over 1% in that interval. One of these patients probably had a pre-existent metastatic tumor with lung mets, and we didn't initially mandate chest x-rays, which we now do, and it speaks to what I've said earlier. And the other patient was diagnosed with metastatic disease at 2 years. It probably was the real deal. The question is whether it pre-existed and was undiagnosed or developed in the interval they were on surveillance. This is just the progression patterns. So this issue of progressors, we really don't have trigger points, unlike prostate cancer where we have PSA that we think is a trigger point for treating progression, or maybe it's a too late marker for diagnosing progression, but we do not have at this time a prognostic factor. And if one of the eminences here in molecular genetics could give me a marker or us a marker, then I could serially biopsy these patients, which I'd love to do, and our REB would approve. Then we would have a signature event that we could use. But what does seem to be a trigger is faster growth. And we've looked at this, and we've just published a collection of patients. Now, they're not all truly small renal masses, but they're smaller tumors, T1s. And we pooled the world's experience and just published that this year. And you can see the non-progressors and the progressors. And if you look across here, and it's a little hard for me to point, but the long story short is patients that are progressors are growing fast. So they tend to be bigger tumors, and they have a faster growth rate. We don't have a threshold to use, but that seems to be a validated, or we're validating the marker. This is a little concerning, though, that here's a benign tumor plot, and we just published this looking at renal oncocytomas, and these are patients with oncocytic biopsies or tumors on nephrectomy. And looking at the growth rate where we had an opportunity to study them is around 30 patients. You can see, even though they're oncocytomas, there's quite a growth rate. In fact, the pattern of growth is a little more aggressive than what we saw on all small renal masses. So there are a lot of things that we don't understand here. And just to finish up, the concerns about metastatic disease, I think, are muddied because of these population studies, and this is the most commonly quoted one, looking at newly diagnosed tumors and the presence of metastases. And very small tumors have metastatic disease at a population basis, and it's my belief that virtually all these present with metastatic disease, and this does not translate into progression to the 5% or whatever the rate is in these small masses, and I could speak to that later. So do we lose a window of opportunity when we do initial active surveillance that a partial nephrectomy becomes a nephrectomy or some such? We don't have evidence for that. I've spoken to serial imaging. We're using much more ultrasound now. We haven't validated the interval, but we do chest x-rays. Patient and doctor acceptance is a big issue here, and I think we saw that on the street of London here today. And we do not have validated guidelines. So the take-home message here is we're still not at a point that we can select a young or a fit patient for active surveillance, but we're learning a lot about the biology, so we're coming at this from the clinical side, and hopefully we'll meet with you guys and you'll teach us something about this. So, and I think I'll just quickly finish there and speak to other things. Thank you.